Well, thank you very much for that introduction. Good afternoon, everyone. What I have been asked to do is to talk about aortic diseases and what are the various causes and how do we manage them. And so just a little review, although I know Dr. Sharma just went over some of this, but let me review it a little more. So when we talk about aortic diseases, we're talking about from the heart out to the rest of the body. So the main pumping chamber, as you see up there, is the left ventricle. It pumps the blood to the rest of the body. But to get to the rest of the body, it has to go through the aortic valve and then into the aorta, the big blood tube that transmits all of that oxygenated blood to the rest of the body. The aortic valve acts to open up when the heart is contracting and then close down when the heart is relaxing, and thus it prevents blood from flowing back into the heart when the heart is relaxed. When we talk about diseases of the aorta, we should distinguish the particular portion of the aorta that we're talking about. You see the diagram to your right where the aorta goes from the part that just starts is just at the aortic valve. It goes up into the top of your chest, then the back part of your chest down into your abdomen, and eventually goes down, it splits and goes into the arteries that go into the legs. So when we think about the aorta and we talk about aortic diseases, it can either be in the chest or the abdomen. In the chest, it's important to distinguish diseases that are in the first part of the aorta, the ascending aorta, that is right above the heart going up to the head and neck vessels, the arch that goes across the top of the chest, and then the descending aorta while in the chest. As we'll talk about in a second, they're different diseases that occur in different locations. Then the aorta continues into the abdomen, into the belly, where we again see the same thing but different as far as the types of diseases that you can see. So there are two basic types. I'm oversimplifying a little bit, but there are two basic types of aortic disease. There is enlargement of the aorta, of the big blood tube, also called ectasia or an aneurysm, and then there is narrowing. When there is narrowing of the aorta, it is usually due to a congenital defect. It can occur otherwise, but the most common type of narrowing is congenital, and it's called coarctation of the aorta. I will show you some of these in just a little bit. Now, if we think about things that cause the aorta to enlarge, an aneurysm, if you will, there are various causes that can be involved. One of the ones that we can see is when there is traumatic disease. If someone is in an auto accident or something like that, the sudden deceleration that occurs can actually lead to a tear in the aorta called a dissection. There are various congenital defects that can lead to an aortic aneurysm, and this is can be particularly significant in youngsters, where we can see children or teenagers who have an aortic aneurysm, and that is not uncommonly due to a genetic defect where they have the connective tissue that holds the body and the aorta together is weaker than normal, and they can be at risk of developing a dissection. Interestingly enough, diseases of the aortic valve itself, we're going to talk about that in a second, can also be associated with diseases of the aorta. So you heard Dr. Sharma talk about someone who had aortic valve disease with two cusps, a so-called bicuspid aortic valve. I do adult congenital heart disease. Probably the most common defect we see, one of the most common, is a bicuspid aortic valve, two cusps rather than the three cusps that all of us have. But one of our big concerns is not just what's going to happen to that valve, but also what's going to happen to the aorta, because children or adults with a bicuspid valve also have a high risk of getting enlargement of their aorta. And in fact, we not infrequently will need to intervene on someone who has a bicuspid valve, not because the valve disease is so severe, but because the aorta has become enlarged. Other things that can do it are high blood pressure, infections, and inflammatory conditions. So a wide variety of things can cause enlargement of the aorta or a dissection, but the ones that we are really attuned to are those genetic or congenital defects, because then we know what the natural history is and how to intervene to try to prevent problems. Now, when we talk about aortic aneurysms in the belly, that's a somewhat different thing. And for all the men in the audience, and there was a question about cigarette smoking earlier, this is an important thing, that we know that there's an important association between prior cigarette smoking and abdominal aortic aneurysms, particularly in males. And therefore, it is recommended, as you see there, that there is one-time screening for an abdominal aortic enlargement in men between 65 and 75 years who have ever smoked. We're not sure if it applies to women, but it's something to think about. But we're pretty sure in men that that's a real risk factor for developing an aortic aneurysm. So again, one-time screening is recommended for men who have smoked, who are now aged between 65 and 75. Pardon me. Now, how do we manage an aortic aneurysm when we detect it? Well, the first thing, as Dr. Sharma mentioned also, is that just because we detect an aneurysm or an enlargement of the aorta, that doesn't mean that it necessarily needs to be treated at that time. So, as he mentioned, there are certain sizes where we know if the aorta gets that big, then the risk of something bad happening, and that's typically dissection or a tearing, goes way up. But before that time, if we monitor the patients, they don't necessarily need surgery. But when we do need to intervene, there are two things that we can do. Probably the more common thing, particularly in the chest, is surgery, where typically we actually replace the diseased portion of the aorta, thus, in essence, eliminating the chance that that's going to dissect again. In patients who also have a problem with their aortic valve, it's typically done as a combined procedure, where the aortic valve is replaced and an aortic so-called conduit is put in place, artificial material that actually replaces part of the aorta. Particularly if the aneurysm is in the belly, in the abdomen, then a stent can often be used, where we have something that is typically expanded by a balloon, and you can fix the aneurysm in the belly without having to do major surgery. The most common cause of narrowing of the aorta is, as I mentioned, a congenital abnormality, and the most common is so-called coarctation. In rare cases, we can see acquired diseases such as inflammation or hardening of the arteries causing this, but the most common by far is coarctation. So here you have a diagram or a drawing on your right side showing what a coarctation is, which is a congenital narrowing of the aorta, and it typically occurs right around the arch portion of the aorta, joins the descending aorta in the chest, typically just beyond the vessels that go up to the head and neck. The treatment usually is balloon enlargement and a stent, although in some cases surgery may be needed. We look for this when we, particularly in children and young adults, and one of the tip-offs can be if a young person has significant high blood pressure, it turns out that when you have coarctation of the aorta, for a variety of reasons, they can get particularly high blood pressure, especially in their arms. So by the way, one of the ways that I can diagnose this right at the bedside is we measure the blood pressure in the arms and the legs. Take a look at that first drawing. You can well imagine how the arm, which is at the top, where the blood vessels would be at the top part, would have much higher blood pressure than beyond that narrowing that goes down to perfuse, to bring blood to the legs. So one of the things in our adult clinic that we do on every patient is we measure the arm blood pressure and the leg blood pressure, and if there's a big difference, that's a suggestion that coarctation could be present. Now let's go from the aorta, the big blood tube, to the aortic valve. The aortic valve, again, is supposed to be a one-way valve that opens during what we call systole, when the heart contracts, and closes during the relaxation phase, or diastole. It can become diseased in two ways. One is narrowing, we call it stenosis, because it doesn't open sufficiently and it limits the blood flow coming out of the heart, or it can leak where it doesn't close appropriately, and we call this aortic regurgitation or aortic insufficiency. Here are some drawings to show you the common causes. In developed countries, rheumatic disease coming from a rheumatic strep throat is not a common cause. In developing countries, it's more likely. In the United States, the two most common causes by far are a bicuspid valve, you're born with that problem, or so-called acquired calcific disease. Some people call it senile aortic stenosis. I resemble that remark. I don't like it. Just because you're getting older doesn't mean you're senile. So we'll just say it can be associated with older folks. So what's the best way if I'm going in to see a patient and the diagnosis is question aortic stenosis? How do I intuit what the cause may be? Before I go in the room, as I look at the chart, I look at the age of the patient. And if the age of the patient is 40, it's probably a bicuspid valve. And if the age of the patient is 70, it's probably acquired calcific disease. As indicated, there are only three major causes, and rheumatic is not very common in the United States. The way the heart adapts to this problem is it's like the heart is lifting weights, because to get the blood out of the heart, it has to pump against this narrowing, so the muscle gets thicker. We call that hypertrophy, and we can see that on an ultrasound or an echocardiogram, as Dr. Farkas will show you in just a couple of minutes. So if we see a narrowed valve and a thick wall to the heart, be really concerned that that's aortic stenosis. So this is the diagram of it. It's when you're watering the garden and you have a hose and you put your thumb over the end of the hose, that's aortic stenosis. So what happens when you put your thumb over the end? The jet goes faster, right? So what we have here is high pressure, the narrowing of the valve, and then normal pressure in the aorta. And as Dr. Farkas will show you, we can actually measure the increase in velocity that occurs because of that narrowing, and thus non-invasively estimate how narrowed that valve is. So we look for that high flow that occurs because of the narrowing. This is a diagram that again shows it. You see the thick wall, the high pressure in the left ventricle, and the narrowed valve of the aortic stenosis. Here are just some examples, some surgical specimens, bicuspid valve, a unicuspid valve. So here's a patient who was born with just one leaflet rather than the three that you and I have. And you can see aortic valve disease that's congenital with a unicuspid valve, a bicuspid, a tricuspid, or a quadricuspid valve. The number of cusps is not necessarily indicative, except when you have one cusp or two cusps, you will often have aortic stenosis. We don't see this very often, but the thickening that you can see of the valve with rheumatic heart disease. Dr. Sharma referenced this, but this shows you, this is something I use more with the medical students and the other health sciences students, but this looks at survival versus age. And notice what the diagram shows, that over 10, 20, 30, 40, 50 years of life, the typical patient is going to be in what we call the latent period, where there is very little loss of life until the person becomes symptomatic, and that's the inflection point. When symptoms occur with aortic stenosis, look what happens to survival. It falls off dramatically. And the three major symptoms we look for are chest pain or angina, heart failure symptoms like shortness of breath, and passing out or syncope. The smaller diagram shows the life expectancy with each of those, but notice we're talking a couple of years once you have severe aortic stenosis and you develop symptoms. Interesting thing on this slide is look when it's from. This was reported in 1968. The data are still true today, that if you don't treat symptomatic aortic stenosis, that's what happens. So we need to be surveillant for people who may have aortic stenosis, and we want to make sure that they don't have symptoms, because the problem can be is symptoms can develop very slowly, and as Dr. Sharma suggested, they may just attribute their reduced exercise capacity, oh, I'm just getting older. Well, if you have a murmur, there's a question about that, especially if the person seems to be slowing down or a little more short of breath. Be concerned, be very concerned, because there's something that could be really bad going on. The great news is that if we find out that the person has severe symptomatic aortic stenosis, the survival curve is dramatically changed by doing either TAVR or SAVR, doing either the expandable, implantable valve or surgery. Mortality is dramatically reduced, and symptoms are either relieved or much improved. Dr. Sharma touched on this. The options that we have are transcatheter aortic valve replacement or surgical aortic valve replacement. In the past, TAVR was typically reserved for high-risk, often elderly patients. A paper appeared in the New England Journal of Medicine yesterday looking at TAVR in low and intermediate risk patients, and the results were every bit as good as surgical repair. So TAVR really is a good option. One of the issues, though, is on the last point, which is, as was mentioned a few minutes ago, a mechanical valve is often preferred in younger patients because, for reasons we don't understand, a bioprosthetic valve, a PIG valve or other biosynthetic valve, doesn't last as long in young people as in older people. We don't understand why, but it is a fact. So that if we have a younger person who gets a bioprosthetic valve, whether it's at surgery or with TAVR, there's a pretty good likelihood, at least based on current valves, that they're going to need another procedure at some point in the future. So whether you do a mechanical valve or a bioprosthetic valve, this is definitely shared decision-making. It isn't that I go in and tell the patient, you're going to have this. It's we sit down together and debate, or not debate, discuss the strengths and the weaknesses of each approach. For most patients who are at the more extremes of age, it's pretty straightforward. I would really do a bioprosthetic valve in an elderly patient, and someone in their 20s, I'm going to really push for a mechanical valve. It gets tougher 40s and 50s and 60s. That's where you have to have shared decision making, in my opinion. And we'll finish up with leaking of the valve. Regurgitation, also called insufficiency, results from failure of the valve leaflets to close completely, thereby getting reversed flow into the heart. It can be due to disease of the valve or the supporting structures, and unlike the typical patient with aortic stenosis, it can appear chronically or acutely. So just think about it. If you have a valve and for some reason it suddenly tears, you're going to get instant aortic regurgitation. On the other hand, if you have gradual deterioration of the valve, that's going to appear chronically. For someone who has the acute tear of the valve or other problem, an infection of the valve that causes severe aortic regurgitation, that is often not well tolerated medically, and we often have to do urgent surgery. There are multiple etiologies: rheumatic, endocarditis, connective tissue disease, and unlike aortic stenosis, where it's the weightlifter who gets the big, thick muscles, hypertrophy, with aortic regurgitation that's been present over months and years, the heart actually enlarges to actually accommodate the leaking that's occurring in it, and the adaptation is enlargement of the heart. Here's an example. You see the yellow and blue. You'll see it much more in the next talk when Dr. Farkash actually demonstrates this with the imaging studies that we can do. But this is the leaking coming from the aorta back into the left ventricle while the heart is relaxed. And again, here are some pictures showing you examples of it. Here's on your left an infection of the valve that can cause acute, severe leaking of the valve, or it can cause chronic disease. If the infection comes along and stays there for a while, it may be a more chronic presentation. Here's a rheumatic valve. Again, we don't see that very often. And then sort of the worst case scenario is someone who has Marfan syndrome, which is a genetic abnormality where the patients have weakness of the connective tissue in the body, and this can lead to dissection of the aorta, and it can dissect all the way down to the aortic valve. So you not only have a tear in the aorta, but you have a leaking aortic valve. And in fact, the most common cause of death in Marfan syndrome is just that, is a dissection, often involving the aortic valve. So how do we manage it? Acute severe aortic regurgitation typically requires urgent aortic valve replacement. Asymptomatic but minimally symptomatic patients with chronic aortic regurgitation, we need to think about doing something if the heart continues to enlarge or its squeezing ability becomes reduced. And it's clear cut that someone who has severe aortic regurgitation and has symptoms requires treatment. That's usually AVR, aortic valve replacement, although in some situations and with very experienced surgeons, we can sometimes repair an aortic valve for a patient who has aortic regurgitation. So that was a quick summary of the diseases that you can see of the aorta itself or the aortic valve, and the management strategies that we can use for each. So thank you for your attention, and I don't know if we have time for any questions, or we have time for questions. So are there any questions that I can try to answer?
First off, I appreciate the way you put this in terms that a country boy like myself can understand, that you and Dr. Sharma have done a nice job doing that.
Thank you.
Is there any studies that support the idea that blood conditions, and I'll use an example of von Willebrand's. Are there any studies suggesting that having that disease would weaken the aorta or connective tissues in any way where it could lead to a dissection?
So I don't want to be someone's doctor from the stage. I would say it depends on the particular disease, because there are conditions that can affect the blood that also are associated with one of the genes that can cause a weakened aorta. So my answer to your question is it depends, but it's possible. I'm sorry I can't be more definitive.
I have a question. How often have you seen or heard of somebody having a mechanical valve replacement and then having to have it replaced because of infection and being replaced with cadaver?
Yeah, so great question. So when a patient has any type of valve replacement, and even for some types of repairs, one of the critical things that we have to remind patients is they need to take antibiotics prior to dental and certain types of surgical procedures. We call this subacute bacterial endocarditis, or SBE, prophylaxis. The reason it's really important, and your question is a great question, is because in the last 10 or 20 years, the recommendations for the use of antibiotics prior to dental work have really decreased. We used to recommend it for anyone, almost anyone, who had any type of valve problem. We now know that that actually can lead to more problems of taking the antibiotics, because you can get resistant organisms, and thus it doesn't seem to make sense to use it as widely as we used it before. But the flip side of that is that I've seen patients who thought that applied to them, that they didn't need to take their antibiotics anymore, and then they can have the complication that you mentioned. And that is probably the worst outcome for a patient with a mechanical or even a bioprosthetic valve, is to get that infected. Now, if we detect it early enough, we can do, obviously give antibiotics, and if they need it, repeat surgery. But it is a largely, not completely, but largely preventable complication. So every time I see a patient in the office with a mechanical or a bioprosthetic valve, my last comment to the patient before we say the goodbyes is to remind them to take their antibiotics before dental procedures and certain surgical procedures. I think because there is pretty good awareness of this, the answer to your question is it's not common to see someone who has an infection of their valve, but I have seen it in my career, and it is often a messy situation since it's largely preventable. If any of you out there are sitting with a valve or thinking about getting one, just remember 100% of the time you need to take an antibiotic for dental procedures and for certain surgical procedures. Which ones, we sometimes have to talk about, but it's important to not forget that. As a matter of fact, I bore my patients with the following scenario. I say, okay, let's say you're in Alaska, far from medical care, but they think they need to do surgery urgently, but they can't get a hold of me, your cardiologist, to know whether you should get an antibiotic or not. What should you do? And the correct answer is, if you're not sure, take the antibiotic to try to prevent the complication that you're talking about. So fortunately, patients listen to that, and I don't see prosthetic valve endocarditis very frequently.
So now follow-up question to that. How often do you see it when there has been no surgical or no dental procedure done?
Yeah, so another great question. It's not common, but it occurs. And it even can occur to seemingly otherwise healthy people. I have a patient who ended up with an aortic valve replacement after an accidental bite from another person. He was a caregiver and had no known valve disease and had no other, didn't have a dental procedure or anything else, and ended up with endocarditis, or an infection of a heart valve. So not common, but yes, it occurs.
Hey, I have a question with it was mentioned about Marfan's and connective tissue disorders that can lead to the aortic dissection. Is there any others besides Marfan's, and how would a person know they would have something like that?
Yeah, great question. So the answer is yes, there are any number of other syndromes. Two of the more common ones are Loeys-Dietz syndrome, LDS, and Ehlers-Danlos syndrome, but there are even others. So the tip-off to this are a couple of things. One, is there a family history of a problem? When I hear a family history, someone in the family had an aortic dissection, I'm immediately hyperacute to look for any congenital abnormality. The second thing is, does the patient have evidence of hypermobility? When you have problems with your connective tissue, those kids or adults are typically hypermobile. So one of the tests we do is the thumb sign. So I hope none of you are positive in here. You take your thumb and wrap your hand around it, okay? You shouldn't see your thumb sticking out the far side. If you do, I'll give you my business card so you can see me later. So looking for signs of hypermobility like the thumb sign is useful. There are also skeletal manifestations of both Marfan's, of Loeys-Dietz, and other syndromes that can alert you to it. So a couple of things that we look for are, one, someone who has so-called pectus excavatum, someone who has a lot of scoliosis to their back, someone who has wide-set eyes, hyperteliorism, someone who has, and I know someone in this room who does have it, someone who has what we call a bifid uvula, in the back of your mouth when you look in there. If you see two of them or they're split, that would be another person who, where that's a sign that they could have a connective tissue disorder. So those are some of the things that we can look for just on physical exam or from history that would suggest a genetic abnormality. Great question. All good questions.